nos acompañan en esta tercera sesión de webinar sobre los temas de evaluación, poniendo el foco en equidad, que para nosotros ha sido una experiencia muy interesante y espero que para los que han estado en las 3 sesiones de webinar también lo hayan sido, ¿no? En esta ocasión, que es nuestra tercera sesión, ¿cierto?, de webinar, que hemos estado trabajando en conjunto, ¿cierto?, con Sanjeev, que nos ha estado acompañando en cada una de las sesiones. Sanjeev, para los que se suman quizás por primera vez hoy, es una persona con una vasta experiencia en materia de evaluación, en los temas, digamos, de complejidad que implica hoy en día muchos los problemas y los temas de salud, y sobre todo cuando queremos evaluar y mirar resultados en el ámbito de equidad, ¿no?, de desigualdades en salud. Así que en ese sentido ha sido un aporte y es parte de lo que vamos a estar trabajando en el curso, digamos, del 2022. Quizás reiterar que esto es una iniciativa que se enmarca dentro de un plan y un proyecto, ¿cierto?, que tenemos una oportunidad en la región sobre el abordaje de los determinantes sociales de la salud, en un énfasis en temas de orden más estructural, que tenemos en el marco también de la cooperación suiza, y por lo tanto nos permite mirar estos temas con mediano y largo plazo, ¿no?, ya que es un proyecto y una iniciativa que va a durar los próximos 8 años. Así que por lo tanto vamos a estar permanentemente tocando estos temas y no limitados solo a una serie de webinars. Así que sin más preámbulo, le doy palabra, digamos, a Sanjeev. Recordar a todos que tienen abajo un mundo, una imagen de mundo donde están las traducciones simultáneas que pueden tener al portugués y que pueden tener, digamos, al inglés y al español, ¿no? Así que para los que quieran, digamos, cuando son las ponencias o si quieran plantear algunas preguntas y dudas, siéntanse con la libertad de poder hacerla en su lengua más fácil para cada uno. Así que sin dar, voy a dejar a Sanjeev. Sanjeev va a presentar. Hoy día tenemos 5 personas, 5 panelistas, 4 panelistas y un invitado, ¿cierto?, que nos van a ilustrar sobre mucho, nuevamente, el foco en estos temas, que tiene que ver con mirar algunas cosas más en terreno, más prácticas. Así que voy a dejar a Sanjeev a presentar a los panelistas y para hacer el inicio del webinar. Muchas gracias. Okay, hi Sanjeev, go ahead, please.
Oriel, thank you so much. I'm so delighted to be part of this journey that you've led, Oriel. I have to say, evaluating inequities and evaluating equity-focused interventions, for me, is perhaps the #1 area that evaluators need to focus on. The reason being, I think 9 times out of 10, even when interventions are planned with a focus on issues of inequities, I think in the actual programming and certainly in the evaluation, we pay lip service to the problem itself too. Most of our evaluations continue to be quite mechanical. Most of our evaluations continue to focus on pretty average level focus. So before I introduce, let me sort of call up my slides and then we can get started. Give me 1 second. Sorry, let me start here. So I'm just so delighted that it was really important as Oriel and me constructed this journey. We didn't bring purely a distant, remote academic perspective to this. It was important that we learned from people in the field, people who are actually working on problems of inequities. I work in academic sectors. I continue to be affiliated with the University of Toronto. I work with the Gates Foundation. Both as a funder and an academic, I think my own distance to the problem itself is too much. And I think I'm keen to learn from leaders in the field. So the title of today's session is interesting. It says, towards an ecology of evidence to address inequities, taking practice-based knowledge seriously. My own view is too often we have a very mechanical view of evidence. Very often it's some self-appointed priest who talks about this is the only kind of evidence that matters. I think for problems of inequities, we need to create spaces like what PAHO is doing today to actually understand what kinds of evidence actually matters and how do you go about it. So it's my proud privilege to welcome 5 very, very dear friends. Diane Walter, based in Toronto, working on issues of homelessness. And I've got to say, about 18 months ago when COVID struck, it was amazing to see how doggedly Diane worked on ensuring that despite all odds, despite facing deeply problematic contexts, the services were rendered. Trish Newport, right now sitting in Geneva, but mostly in Congo and Yukon, working with Doctors Without Borders, has worked very intensively with issues of Ebola, worked in war settings, Ebola in Congo, worked in war settings in Iraq. So just delighted. Trish too we have been part of multiple evaluation settings itself too. Sana Contractor, based in Delhi, India, worked on issues of gender violence, social exclusion. We worked together many years ago on an absolutely fantastic program on engaging with men to reduce gender violence. Tim Ward, who's been a dear friend for the last 15 years, he used to head the Health Equities Group in the Scottish Government. Now he works with digital health in the Scottish Government. So he's really been a genuine companion in terms of thinking about evaluation's role. We continue to challenge each other. Ray Posson, one of the folks who's really influenced me to both stay in evaluation, but certainly someone I look up to mentorship, the developer of realist evaluation, and someone who's really gotten me to think more deeply in a more excited way about evaluation itself. So in the next 15 to 18 minutes, I just want to tell you what we're trying to achieve. We started this journey about 6 weeks ago, where we talked about why evaluations matter. 3 weeks ago, we had a deep dive into realist evaluation and how do we take issues of context seriously. Today, we'll sort of talk about this notion of what are the different kinds of evidence that actually matters. The way I'm going to go about it is some introduction for why we actually don't need one piece of evidence. We actually need multiple kinds of evidence. I'm going to make the argument, and the structure of today is to be really sort of saying, no, I don't think from this distance view of evidence is not good enough. What Ray's great contribution to the field of evaluation was to take context and mechanisms seriously. And part of today is to sort of learn from the practitioners, folks who are from policymakers and practice settings, folks who actually have a hands-on experience with context itself. Some ideas on ways forward. Then comes the heart of today, where with the order of presentation, Trish will lead the charge, then on to Sana, Diane, and then Tim, and then over to Ray for ideas for discussion, and then we'll sort of open it up more broadly. So I think I wanted to sort of really echo what Oriel, sort of her introductory comments, is vital. I'm just so delighted. Oriel and me have worked together for the last 12 years. The journey started many years ago in Chile. Now that she's moved to PAHO, it's quite exciting to sort of continue this journey. Part of what we are doing is these webinars are going to feed into an introductory course on evaluating inequities, which in turn, we're just having these conversations on how do we actually get serious in building capacities of evaluators to evaluate inequities. I've got to stress, I don't think in most courses, and I've seen in universities, we actually take inequities seriously in either in the conceptualization stage or in the measurement stage. Our conversations are moving towards how do we move towards an accessible online platform that evaluators can access to actually learn about it. Some of this work will intersect with some of the work we're doing in India with the Gates Foundation and its partners and the government of India, but also more broadly with PAHO's interest itself too. But all of this is really a connection to, I think, as the sustainable development goals, as in multiple development settings, are getting serious about achieving some of these goals and actually thinking about these goals in a more serious way, how do we build evaluation competencies? So the question for today is, imagine Diane working on homelessness in Toronto. My question to her was really, what kinds of evidence do we need to act on inequities? And again, you sort of realize even the act of framing this question, there's a slightly distant academic nature to this question. It's not as though Diane or Trish on a daily basis are not acting on, but they're not necessarily looking for, here's the evidence base. Even the act of constructing this question is slightly mechanical. I want to acknowledge that. The reality is that people get on with solving problems without reifying this thing called an evidence base, et cetera, et cetera. That's often the way academics talk. So I want to also acknowledge that my own construction of this question is somewhat limited. I'm sure Diane, Trish, Sana, and Tim will sort of set us straight on that. But the problem here is one of this thing called an evidence, where let's just imagine this program that's worked rather well in Southampton, England, and you're implementing a program in Kanpur, India. How do you know a program that's worked in Southampton is going to work in Kanpur, India? It's entirely possible. What works in Southampton might not work in Kanpur. Further, what might work in Kanpur might not work in Nagpur, both places in India. By the way, there are subtle cricket hints to Ray in the choice of places. The important part of this is local context matters deeply. Diane works on homelessness. It's entirely possible the drop-in that she works in, that she leads in Toronto, might not work as well in rural Ontario. So simply providing information on impacts is simply not good enough. You've got to say what's worked there might work in your setting. It's relevant. So I think as evaluators, we've not done a good enough job of raising the relevance of relevance itself. And in the way we talk about evidence, more often than not, I find a modesty and humility lacking. We often go along and say, we found great evidence that this works beautifully in Manitoba. Let's apply this in Lucknow. It may not work. And I think thinking about context is needed. There's a wonderful quote from two leaders, two philosophers and philosophers that I really appreciate, Nancy Cartwright and Jeremy Hardy, where they say that the fact that it worked there is not straightforwardly relevant to the conclusion that it'll work here. So all of our evaluation problems are proving something worked there and somehow implying it's going to work here. And that is not just to do with a fact having established by a randomized clinical trial. Further, more from Cartwright and Hardy, I don't think we do a good enough job of learning from failures. In multiple settings that I work in, whether in a university or a foundation setting, we often give thumbs up, thumbs down to a program. Actually going deep on why it didn't work, I don't think we do a good enough job. So again, Cartwright said there are too many examples where doing here what worked there failed because of a failure to see what was relevant to success beyond the fact that the intervention had worked somewhere else. And that's exactly the kind of game we play. We kind of say, well, actually, we found a drop-in in one place. Let's apply this all across Ontario, etc. That's a challenge. And this is a pretty deep challenge. And how do we make evidence matter? So if you had more time, and I have only another 10 minutes or so, but I want you to do a thought experiment. Focus on an intervention that you've been interested in evaluating that has a focus on inequities. Ask yourself, what did you hope to learn from the evaluation of such an intervention? Did the evaluation itself have multiple purposes, or was it a much more of a thumbs up, thumbs down? We are going to provide evidence of impacts. And ask yourself, did you actually learn from this intervention? Okay, if we have more time, we'll discuss it. But this is going to be awfully familiar to Tim, and this is going to be my jumping off point for today. And this really helped frame some of my thinking. And Tim was very much part of that journey 14, 15 years ago when we got deep into it. This was an intervention in one of the poorest parts of Scotland, Paisley, the focus was on health inequities. And the idea was to reach through a series of measures some of the poorest people in Paisley in the hope that they would come through the intervention. We provide them risk screening, a whole bunch of services, including health coaching. The hope was that if some of the most disadvantaged folks came through the doors, and they came through disproportionately through the doors, this would lead towards better outcomes for them. And this in turn could lead towards a reduction in health inequalities. I'm going to frame this example as my jumping off point for framing this discussion. So right away, notice the fact that once you start thinking about programs in this light, you've got to ask yourself, what are mechanisms by which this program is going to work? Or what are some of the assumptions you're making? Now notice you're not just, right away I want you to appreciate, the evidence you've been tasked to develop is not purely evidence of impacts. You've got to be asking, did this mechanism of empowering poor people to take control of their lives actually get activated? Did the program actually empower people? Notice you're asking for questions on deeper kinds of evidence. Is there evidence that some of these assumptions that was implicitly assumed, that there was any empirical evidence for that itself too? So this is very much now going into a deeper realist stance on thinking about this intervention. There is a reach aspect to it. There's a screening aspect to it. There's a health coaching aspect to it. And part of getting the program right is you look at different kinds of evidence, and Ray will argue, and I totally agree. You look for both the gray literature. You don't sit around and get too sophisticated about hierarchies of evidence and all that in a mechanical way. You're being opportunistic about it. And basically going through a synthesis, you say, actually, what we have learned is this is the best way to reach people in these settings, et cetera, et cetera. So if you look through Have a Heart Paisley, and I don't have too much time, and Tim and me have written papers on this, there are some aspects about a program providing insights for policies. So Have a Heart Paisley fed into other kinds of initiatives focused on the most disadvantaged individuals. Have a Heart Paisley also provided organizational learning. Actually, that's not the way to structure health coaching. As an example, so actually having just 2 health coach for 100 clients is simply not good enough, etc. Process learning. You're learning about how health coaching works, etc. The fourth kind of learning is especially important because you actually are making rather pompous assumptions about clients' lives that you actually don't quite know. So as Have a Heart Paisley was being implemented, there were assumptions being made that most of them are unemployed, et cetera, then they can come in at any single time. That's simply not true. And of course, there are, you're hoping to learn about impacts, etc. So partly what I want you to appreciate, basically you may have an intervention with very different components trying to reach. Each of these different components work with different timescales. So basically, a health coach might take a longer time to influence individuals as opposed to some sort of much more of a medical sort of intervention. You've got to kind of factor that into your evaluation. One big challenge across the board for inequities is most evaluations are funded for a shorter time. The actual interventions take much longer. Inequities means some people have more need than others. We are still stuck in an average view of things. We don't often understand the needs of different segments of folks itself too. Fourth, it's not so much about the idea that the outcomes themselves have changed, but even if you have good processes, we often don't have good measures of process itself. So the deeper question we've got to ask is when we do the evaluation, it's not purely did it have impacts. That's one super important question. But there's a whole range of different kinds of learnings that are possible. So I want to stress this, that one role of evidence is it helps you reflect. You got this wrong. Your maternal health intervention was not well thought out. You might want to rethink, even before we get into the impacts part of it, etc. You can have evidence for effectiveness, some kind of impacts, etc. But you might also have evidence to say, Sanjeev, you need this program, this homeless intervention in Toronto needs to be better connected to the city. or the city is not supporting this intervention. Or connectivity is as important as impact itself. Evidence for reach. You're really reaching the usual suspects. You're not reaching the people who most need the intervention. Then you might have evidence for who's engaging with the intervention. It's the ones who are the kind of usual suspects who are engaging, etc. Super important. Are the needs of the community being met by this intervention? Do we need something else? So there's the evidence of unmet need. Then comes evidence for actual differential impacts. There are across different segments, there are different impacts. But you also want as a policy maker to say, should we sustain the program? Should have a hard place continue? Or should we end it now? Notice the fact that different roles for evidence. So I don't have time to go through it in great detail, but I think it's useful to think about evidence at the project level. This project, I'm going to learn about processes, organizations, around clients' needs, around context and support structures, implementation, etc. And you want to look at the system need. So this graph, I originally made this when we thought about poverty reduction in Ontario, where you're saying actually Diane's drop-in works rather well, is project level evidence. But that might be still a mile away from actually saying, what does Toronto actually need? And what are the larger, broader ecology of needs? What are the ecology of interventions needed? Will this kind of intervention have impacts on scale? Questions around system level context, system level sustainability. So I want to introduce this idea that we need to move away from purely thinking about project level information. We need to worry about system level information. So 4 more minutes and then over to Trish. I want to sort of make the argument, this bad habit of simply saying we have evidence that this intervention works is simply not good enough. We have to basically empower whether the implementer or the researcher or the evaluator to start thinking about different kinds of evidence and the relationship between them. This is actually Oriel's work from 2008, Closing the Gap, generation on important health equity intervention. Part of the challenge is to start locating, so she talks about structural determinants of health inequities, the intermediate determinants, as well as the longer term impacts on equity and well-being. For each of these issues, we've got to ask tough questions about, will this intervention actually bring about change? How long should we continue this intervention? How does this intervention actually address one of the structural determinants of health or an intermediate determinant? How do we connect between different existing interventions? So Diane is deeply interested in not just her drop-in, but how her drop-in connects with other kinds of services being offered for the homeless. But the critical part in thinking about impacts that I think a realist perspective brings with it, you've got to think through processes. A single intervention by itself does not change homelessness. But you've got to ask yourself, are there mutually reinforcing processes that start? You've got to ask yourself tough questions about timelines. How long will it take? What are the dynamics of change? How does the evaluation itself bring coherence? How do we understand issues of segmentation and issues of sustainability? So I'm getting out of time, but I want to stress that there are different goals of evaluation. Sometimes evaluators help develop the intervention itself. And there was a lovely soup analogy that I won't go into. That's developmental. Sometimes evaluators will help improve the intervention. That's formative. And finally, you're giving a thumbs up or thumbs down. So part of, as we think about this ecology of evidence, we have got to think through what kind of evidence is experiential, what is much more theoretical, what's contextual, what role does evaluations both of systems and projects bring to the table. And I think sometimes there's a bad habit about talking about evidence much more at the global level. Across 5,000 studies, we found this average. And Ray, more than anybody else I know, has done more than to challenge and bring a focus on issues of local context. Last slide. As I think about what do all these ideas mean for evaluation, I'm much more interested. This is a very real issue because we're working on health equities for a large problem in India, in India's most populated state, where I'm moving away from a single evaluation. I'm interested in networks of learning. How do we think about networks with different teams with different types of methods and approaches? How do we actually build in some kind of competitive learning, not simply just depending on this one grand evaluation result at the end? How do we more cleverly mix different purposes and approaches? How do we build connections? There's not a single intervention in the world, whether at the $100 billion level or the $10 level, that's simply by itself the only show in town. How do you build connections between that intervention and existing systems, etc.? How do we move away from this bad habit of just focusing on immediate impacts or intermediate impacts and actually think about sustainable impacts? And all of this has to be done with a humility that often our own imaginations of how to change the world, and certainly how to address problems of inequities, are super limited in the beginning. Our job is to have a much more healthier imagination, rethink our theories of change in a much more emergent way. So that sets the stage. Let me pass it on to Trish to take it away to build on this. Trish, over to you.
Thanks, Sanjeev. I will just share my screen. Right to the beginning. Okay. So to start, Sanjeev, thank you so much for the invitation to come. To be clear, I am not an academic. So I am very much a pragmatic implementer and manager of emergency response. And for the last 14 years, I've been involved in emergency response for humanitarian aid. And this has really framed the way that I think about evaluation, how and what we should be evaluating. And because in emergency response, we can't afford to wait 6 months, a year, or longer to do an evaluation to identify what the problems were or if we were really attaining our objectives. In emergency response, we really have to be identifying the problems along the way and adapting and changing. So I see a big overlap between evaluation and program implementation and follow-up. And so this really comes out in what I'm going to talk about, because when Sanjeev asked me to talk about an ecology of evidence to address inequities, the first thing I thought about was an experience in Niger in 2010. So in 2010, the under 5 mortality rate in Niger was extremely high. Across the board, it was pretty much above the emergency threshold. We as MSF, or Doctors Without Borders, were running malnutrition programs really mostly along the border between Niger and Nigeria. We had massive quantities of programs because malnutrition was such a huge problem. But despite the number of programs we had, the under 5 mortality rate in the areas where we were working was still above the emergency threshold. So it's more than 2 deaths per 10,000 children per day. It's huge. And so we decided to try something else. We decided to try to ensure that children in remote villages had access to treatment at the community level for the illnesses that were killing them. So malaria, respiratory tract infections, and diarrhea. As a pilot project, we took 22 villages that were far from the health centers that had high mortality rates. We discussed with the community, we identified people in the community we could train as community health workers. We trained them on how to diagnose and treat those 3 main killers. And then we really made sure the community was aware that this project was available. And so we did it in 22 health centers. In 21 health centers, we saw an immediate huge number of consultations every day in the health facilities. And we started to see that fewer people were actually accessing the hospital and fewer community deaths, even within that first month. Except the 22nd health center, no one was going to. So we went back, we trained the community health workers some more. We made sure that people really knew that this program was available. Nothing. And we had done everything the same, right? Like we had the same community discussions, we'd had the same identification of the community health workers, same training, same health promotion, but no one was going here. So we finally, after 1 month, we had a meeting with all the village members. We put out the invitation to anyone that wanted to come, but we made sure that some key people like representatives of different women's groups were there. And we shared all of the data from all of the other health posts, and then we shared the data from their health post. And we asked them to identify what the problem was to help us assess what it was and help propose a solution. And after a long discussion, it came out that there was a spirit or a ghost in that village that was taking the form of the community health worker. And so people didn't know if it was the community health worker that was treating their child or if it was the ghost. Now this, no matter how much data we had assessed, we would have never been able to identify that this was actually the problem. And so we asked what the solution was, and it involved a ceremony, burning a goat. They didn't have the money for the goat, so we provided the goat. We left the community to deal with the ceremony as they felt it needed to be dealt with. And then within a week, there were consultations at this health post. And then the number of consultations soon became equal as it was to all of the other health posts. We returned a month later to discuss with the community. We wanted to make sure we weren't just leaving it like that, to discuss with them about how it was going, if they were happy with how it was now, if they had any other problems. Everyone was very happy, but I worked with this very wise man who said, was there any way we could have avoided this problem? And it came to be through the discussion that this spirit or ghost had existed in the village for a long time. Everyone knew the health post was not going to work. It's just that we didn't ask about it from the start. And this taught me a huge lesson about when there's problems, asking what could have been done to avoid it in the first place, as well when we're talking about evidence and whether what works here, whether it will work somewhere else, is to ask people that will be involved in the program, people that will be attending it, what could go wrong? And what are the mitigating measures that we could put into place to avoid or reduce the risk of those problems happening? And this, I feel in evaluations, we're not even assessing if these questions were ever asked. And I think that they're really key when we're talking about evidence and transferability of programs, and about looking at the bigger context. So when we're looking at the bigger context, I think we need to be considering context when we're looking at, when we're evaluating a program. Because if we're looking at the program just in its silo, we're not actually looking at what is happening all around. And so I think we need a framework to assess context. Sometimes, Sanjeev, you were mentioning the social determinants of health. In MSF, we look at, in emergency settings, we look at the top priorities. So the priorities that have a huge impact in morbidity and mortality. And so these are really basic things like water, hygiene, sanitation, food and nutrition, shelter, access to quality healthcare. And when we're evaluating a project, if we're not looking at this bigger context and looking at whether these things are being achieved or addressed or not, we can't look at these things will always have an impact on the project that we're evaluating. I'll give you one really basic example. Let me change the slide there. One very basic example is in the Congo. Sexual violence is a huge problem, and we have a large number of very large sexual violence programs. We had one in a village called Mombasa, very old, quite successful, well accepted. And then there was a mass displacement of population towards Mombasa, tens of thousands of people. And whenever there's displacement of the population due to violence, we can assume that there's going to be sexual violence. And we said, so great, we already have the sexual violence program. We will address that, making sure people have non-food items, all these other priorities, but we don't have to worry about sexual violence because we have this. Then we quickly realized in our data, we made sure to identify, are people IDPs that are coming, internally displaced people? There were no displaced people coming. So we went to the displaced people and we talked to them about it. And we asked them to help us identify what the problem was. And for them, even if that program was right there, even if they knew that it existed, they were so busy getting non-food items, dealing with not having shelter, dealing with water. Even if we were addressing those issues, it still takes time to be a displaced person. So for them, even if they needed sexual violence programs, they couldn't access it where it was being done, and we needed to be able to adapt it. So we adapted it with them and asked them, how could we do it? And what are the problems that could come about with this? And how can we mitigate those things? And with the collaboration of the community, we were able to create a program for them. So in summary, I hope I was able to give some different insight into evidence and addressing inequalities. But I think we cannot be addressing inequalities if we're not having the beneficiaries or the people that are accessing the programs or not accessing the programs, helping us to really analyze the data that's coming out, be looking at the evidence and be proposing what the problems are and what the possible solutions are. Because if we're not doing that, and if we're not looking at the bigger context, I don't think we'll ever actually be able to address inequalities properly. Thanks.
Trish, absolutely fantastic. And what a fantastic start. I just got to say 3 parts really resonate. I'm sorry to say that in a majority of interventions I've been a part of, either as an evaluator or as a funder, I have not seen this focus on the local. When you spoke about the 20-second location, and dealing with it in a very serious way, rather than a thumbs up or thumbs down way, but in a way to be helpful, to kind of in a way that actually enhances the possibility of success, and then bringing local knowledge, whether it's of goats, or of any kind of local knowledge, but without making too much of a kind of pretentious judgment that you really are, it's their lives. You've got to meet them where they are itself too. That becomes pretty important. And similarly with this engagement process where you're actually trying to learn about how to plan better, I often see a lot of our work tends to be super mechanical. So all of these are great lessons. Thank you. From Niger to India, Sana Contractor, over to you, please.
Hi, good evening. Good morning, where you are. I am a public health practitioner and researcher from India, and I've been working on reproductive health with marginalized communities in both rural and urban India over the past 15 years or so. I'm a member of several civil society collectives and social movements, and as a practitioner engaged with communities, especially women in communities. One of my roles as a researcher has been in observing and surfacing the discontents, if you will, that arise at the interface of policy, health systems, and communities. And while I've worked on a range of issues, today I wanted to draw on some of that experience, especially in the context of maternal health, to raise some questions about what we consider to be legitimate evidence, why we seek such evidence, and where we go searching for it. To begin with some context, maternal health in India has been an area of policy attention, as it has been globally for the past 20 years, owing in large part to the magnitude of the problem of maternal mortality and morbidity in the country. At the turn of the millennium with the MDGs, India's policy approach to addressing maternal health turned towards ensuring institutional childbirths, which were considered a sort of proxy for safe births. It was a very ambitious goal for a country where a large proportion of women birthed at home. And conditional cash transfers primarily were used as a way to get women into institutions through a policy known as the Jani Suraksha Yojana or the JSY. As you might imagine, very soon the proportional of institutional births rose quite dramatically. But of course, there were inequities across social and economic groups, as well as between states and districts. Moreover, the quality of care was a serious area of concern because health facilities were not sufficiently equipped to handle this increased caseload. And there was an especial dearth of emergency obstetric care and such. So while working in this context, we began to observe the ways in which inequities operated at the interface of this program and women in communities. When public policies like this are imagined, they usually imagine a typical client who is looking for safe childbirth. And once you implement something as large as this in a country as diverse as India, with skewed power relations between the health system and people, between social groups within the community itself, the impact is going to be very different for different groups. And so the stories and experiences that started to emerge, I thought were quite significant to me as a practitioner. But we tend to not give them as much importance as, say, the analysis of large quantitative data sets. So for instance, soon after JSY was introduced, I think around 2009 or 10, there was a large impact evaluation that was done, which showed that, which essentially used two indicators of the rise in institutional childbirths and the rise in antenatal care to say that this program was actually working quite well. It did point out that it needed specific kinds of targeting, so on and so forth. But the kinds of issues that we were seeing emerge were not something that was captured by these indicators. And the kind of evidence that we were being able to present did not also qualify as something that warranted that sort of attention. So, for instance, when Sanjeev and I were talking about this presentation and this program, the first thing that came to mind to me was what is it that is considered legitimate evidence? And that takes me back to this incident sometime around 2012 or 13, when I was at a policy dialogue on maternal health with a very respected senior bureaucrat presenting some evidence from the field. And one of the points that I stressed was the abuse and discrimination that Muslims were facing in the labor rooms. And a small investigation that we had done in one big city in India had revealed that Muslim women specifically face verbal abuse with a particularly sexual content, which alludes to their high fertility. And I brought this up as an issue of concern that needs to be addressed if we are to think of institutions as safe birthing spaces. And in response to this, the bureaucrat was quite upset with me. And he said something like, how do you expect me to take action on this sort of anecdotal evidence? This can be a case of an aberrant, insensitive healthcare provider. How do you expect policy to address it? Of course, subsequently, most systematic research has emerged that highlights the fact that Muslims do face this kind of discrimination at health facilities. But when I reflect about that interaction now, which happened 10 years ago, I'm struck by the ease with which he dismissed what he thought was not representative and was an anecdotal sort of an evidence. And this is a well-intentioned senior policymaker, I must add. But the idea that evidence needs to be presented in a certain form is so deep-rooted that if something less is reported, it is not worthy of being addressed. And I think that's particularly important when we speak about inequities, because it means that we have to be curious rather than dismissive of such stories, even if they are not widespread. Some marginalized groups may be extremely small in number, but their experience is as valid as any large-scale study or data set. So when a program as large as JSY is introduced in a country like India, there are going to be diverse experiences of the program. And even if it is not, if this kind of abuse is not being experienced by everybody, it is still important. Of course, that's not the case. We now know that there's much more abuse that also takes place in the labor rooms. I think what is at the heart of this question is who decides what is a good outcome and what is a good impact. And if we want to use evidence to address inequities, we'll have to be open to this diversity of experiences that communities have with health programs, and also the diversity in what they imagine as good outcomes vis-a-vis maternal health in this case, for example, which means that we have to be open to the idea of co-creating what this good outcome means. Oftentimes when public policies, for instance, in maternal health are designed, they have a rather fixed goal, like increasing institutional childbirths, increasing antenatal care, reducing maternal mortality, what have you. But what communities themselves are experiencing and what their expectations of the program are is that the care be respectful, it be without abuse, it be without coercion, it does not involve being pushed from one facility to another. And these are in fact health rights, but they don't always get the kind of attention that more public healthy sort of indicators do, which can be easily quantified. For instance, in rural Odisha, in this indigenous community where I was once working, there was a deep mistrust with the health system. And that was born from the fact that women were facing coercion at the hands of community health workers. They saw their neighbors who went to the health system neglected. They saw that there was a lack of accountability when somebody died. And all of this contributed to that sense of mistrust. They did go to the institutions, so the numbers did go up, but they also went there because there was an incentive, not because they considered the quality of care to be superior. But this is not factored into how the system or even researchers had imagined a positive outcome. So this sort of evidence requires that you keep your ground to the ear and really try to understand what women have to say about that experiences. And that kind of brings me to what I think is a question that a lot of evaluators need to ask, which is that what are we hoping to do with this evidence? When we bring stories of this sort, they are treated as a resonance, and they are often met with questions about the validity of the experience or whether this evidence was collected with sufficient rigor and so on and so forth. And I think inherent in that sort of questioning is the resistance to acknowledging that different approaches to address problems for different kind of people is required. And the question of whether something is working or not working is an impossible one to answer in a universal sense. So every time a new experience is presented, the reflex is not to be curious about it, but rather to find ways to dismiss it and resort to a more simplistic route of uniformity. And this is a larger problem of public policy in these times, I think, not really specific to health, and especially in India, where I come from, where we are trying to look for more and more centralization of problem solving, because there is an illusion that a strong top-down approach can fix things. But it's absolutely antithetical, I think, to the philosophy of addressing inequities, which on the contrary requires us to not just tolerate, but value the diverse ways of thinking and of expression of agency and of co-creating solutions. And I think our quest for evidence in that light also needs to be more creative, and as Sanjeev said, more humble and grounded. And I hope that as evaluators, we can do a better job of giving this sort of evidence more credibility rather than resorting to what we see as academically sound. I'll just stop there.
Sana, absolutely fantastic, super far-reaching. I cannot help but say 3 or 4 points that come through for me. This notion of a typical client and your push to think about heterogeneities in clients, heterogeneities in experiences, super important. Your push towards moving away from just purely mechanical indicators to ask deeper questions around more complex processes, super well taken. Most importantly, your push for challenging who decides what's legitimate evidence. And I love your call out for curiosity and push towards, I think we need to be much more stronger voices about this action of very easily dismissing experiences, just because, again, self-anointed priest itself. Multiple other points here, but I just feel for me this is really sets the stage for the kinds of dialogues I was hoping to have. From India to addressing homelessness in some of the most difficult parts of Toronto, Diane Walters.
Yes. Thank you, Sanjeev, and good morning and good afternoon to, I'm not sure where you are all physically located, but wherever you are, I hope it's warm because we're not here in Toronto. I'm Diane Walter, and I serve as the Executive Director of Margaret's Housing and Community Support Services, which is kind of a long name, so we're affectionately called Margaret's. I'd like to start by saying evaluation matters to address inequities through the prism of social determinants of health. For me, only to an extent. For a community organization like Margaret's, which serves a largely racialized and Indigenous population, which on a daily basis, we are responding to the needs and demands of individuals at times on an hourly and sometimes even on a 10-minute increment, given the complexity of needs of the population that we serve. Our action, we demand the base responding to the demands of individuals on an hourly basis. Action and appropriate solution in real time matter even more with minimum information. So we're oftentimes operating and responding from a min-spec perspective, and hopefully we get it right. However, I must say there are times, obviously, when the solutions are not perfect, but they're good enough to stave off truly negative outcomes. As a practitioner, I do not have the luxury of waiting for an evaluation. No offense to evaluators out there, including you, Sanjeev, to present the best solution. The problems presented each day require creative thinking for outcomes that will mitigate the impact of situational or systemic inequities. There are no playbooks. There are no manuals to refer to. Solutions are generated in real time. And the staff are obviously trained. We have social workers, individuals with psychology degrees, etc. But we also integrate in our staff team what we call peers, individuals that come from the community, they live in the community, they themselves have experienced homelessness or a substance use issue. So they're integrated into a multidisciplinary team, and we often refer to them as professional non-professionals, and they can inform us with respect to real life experience. I will focus on the pandemic as an example of what we experience in terms of inequity. At the onset of COVID-19, as a community organization, we had little or no access to IPAC or PPEs. The hospitals were prioritized over community organizations. And it's interesting to note that at the time, we thought the experts thought the most vulnerable to the infections were the homeless population, and they were the ones who were most at risk. However, we had no access. I and my staff had to embark on a frenetic pursuit of PPEs and other IPACs. We looked in highly unusual places, and I, in particular, spoke to anyone who would hear my requests. I eventually spoke to an IT, and I stress, an IT individual whose father is a pharmacist and who owns a pharmacy and who was connected to a distributor of PPEs. And that's how we initially got access to PPEs, which is where we ordered our first large distribution of PPEs, which we distributed to clients in the community, and our engagement team would distribute to the homeless folks in the streets or wherever they would find them. I must say, and it was quite heartening, that we did not see large-scale outbreaks in the homeless population, and specifically in our respite or drop-in. I think that's a matter for evaluators and researchers to look into. However, what was poignant was that those in the homeless population that became infected, they are 10 times more likely to require intensive care, because obviously of their health status, age, and protracted harshness of living rough. And they're also 5 times more likely to die within 3 weeks of testing positive, again, because of the precarious health status and living rough and just horrible conditions that they've lived in. The city embarked on a mitigation process of taking homeless people off the streets and putting them in what we call hotel shelters, in single room occupancy. What was discovered in placing this population in hotel shelters was that the opioid deaths increased significantly. We also experienced that in our drop-in and our respite. We had to internally look at what could we do to mitigate these overdoses. What we did, we had to pivot and sort of rejig and reconfigure our workflow design that made sure that those who might be using a particular drug like fentanyl were provided with increased wellness check, especially at night, and staffed by, you know, their own moxie and the fact that they're really smart people. The sort of sussed out who were the heavy users. We do have a policy that though we are low barrier, folks cannot use on site. And, you know, that is theoretical. People, those who use drugs, they're not going to abide by policy. So the staff were particularly interested and vigilant about intensely sort of making sure that those that were heavy users were engaged. And we saw that we did not have the numbers decrease significantly. Again, earlier in the pandemic, we had a period of lockdown in Toronto where the general population could only be seen outside on the streets within a certain period. I think many major cities in North America and Europe employ the same measures. What we did not like about that, I mean, that was fine, that was a mitigating measure, was that our staff, because we're staffed 24 hours, we have sort of odd time staff will come to work, that the staff that were stopped by the police were 100% Black staff. The other staff were not stopped. And I bring this up just to talk about inequities, not only to our population that we serve, but to the general population as well. Obviously, that had, you know, unpleasant impact on the staff. You know, I would, if I'm stopped by police, I'm rattled, and if you're coming to work, your performance will be affected, and certainly your emotional well-being. I will close, though, on a positive note by saying the city, in their wisdom, and there are times when the city does demonstrate wisdom, they realize that there are certain populations or certain demographic that has a low trust level of the system because of historical wrongs and historical abuse by the systems. And those groups are Indigenous, Black, and brown folks. In that program, we created we call them the BEVIT team. It's a Black vaccine equity team, and it was staffed by a professional, generally a social worker, and peers. And they would go out into the community and provide education, and also would engage them in getting them to the vaccine clinics. We run weekly vaccine clinics for them to get vaccinated. One of the byproducts of that, for those who want, first of all, we did see a reduction in hesitancy. We all saw an uptick in the rate of vaccination. But a positive byproduct of that was that we also found folks that had other health concerns that they were not sharing with staff or whatever. And they themselves were attended to and were provided the appropriate referrals. I will close by saying that I don't believe, and certainly this is probably my own personal opinion, and you take it as such, I do not believe we'll ever fundamentally eradicate homelessness nor inequities. And I don't want to get into the reasons why, but what we can do as folks that are committed to social justice and health justice is to commit ourselves to reducing inequities significantly. And if we commit to incrementally doing that, I believe we can see exponential differences. Thank you.
Dan, thank you so much. I do want to call out my formal evaluation working with Diane ended about 3 or 4 years ago. Then barely a day goes by where we don't connect. So this is a genuine partnership, and we do take learning seriously. 5 points come through very clearly, which I think is really important. And this is also resonates with what Trish and Sana say. You almost never have a complete playbook at the beginning, both during COVID and definitely during COVID, but even pre-COVID, you've got to make things up as you go along. So this idea of a dynamic intervention where judgment counts becomes super critical. The question, I think, not just for evaluation, but also for dynamic programming, is how does such learning take place? As I said, Diane and me connect almost on a near daily basis. She would talk to me about how the kinds of learning systems she was building on a daily basis to learn about COVID. I think the fourth part that I think in my conversations with Trish comes through is maybe it's not about how to do things, but how to make sure certain minimal standards are met. And beyond that, you've got to be creative. And I don't feel as an evaluation as a field has been as focused on saying, get the minimal right, then over to you on your judgment and the creative part. I think the fifth part that comes through both in Sana's point, I think partially in Trish's, and certainly in Diane's, is this idea of inequities. You also got to talk about system level discrimination. What about the different mechanisms? I don't think we do that enough in terms of calling it out. Great. From Ontario over to Edinburgh and Glasgow, Tim Warren.
I'm just going to share my slides, hopefully. The joys. Can you see them? Can you see my slides?
I can.
Yeah, we can see. It's slide number 14. You may want to move up, I suspect.
Just here, I'm in slide number 1.
No, you're slide number 14.
Something's going on. Hold on. There's something going wrong. I will stop sharing and reshare and hopefully get it right this time. Apologies, everybody.
We can see slide. We can see it now. We can see slide number 2 right now. Tim, we're fine. You should be fine.
Which slide can you see?
Number 1. I think slide number 1.
Can you see it properly now?
Yeah, we can. Yeah, we can. If you want to make it, if you want to make it slideshow view, that'd be great.
I am in slideshow view on my end, not in yours.
Not in mine, but that's fine. Let's. We can see it. Tim, keep it moving. Your time is
Hold
on.
Okay. So hello, that's who I am. I'll stop there. Obviously, I come from a completely different world to so many of the presentations. I'm central government. I'm, you know, in a nod towards Sana, I'm absolutely about central government, centralized solutions, though I hope not. And I should say that in Scotland, we have, for those who don't know, I suspect you do, a national health service seeking to establish a national care service, care-free at the point of need, and a very different kind of ecology that we're working in. And so vastly different from the Congo, obviously. But there is a commitment from the Scottish Government to health inequalities. I put some links in here. You can see Chief Medical Officer's annual report focus on reducing health inequalities. Fairer Scotland, duty on public bodies to review any new activity for its impact on health inequalities. Can you see the train carriage, Sanjeev? Sanjeev, can you see the train carriage?
Sorry, yes, we can. It looks very inviting. Over.
Yes, well, I was on a train going from Edinburgh to Glasgow to visit Sanjeev, and I sat down on a seat. It was actually much scabbier than this, and there was I sat down, and at the first stop, 3 other guys got on wearing donkey jackets, and they saw I had papers in front of me, and they said with an accusing finger in my face, "Are you health and safety?" Because they're the people who are a pain to workmen, making them wear hard hats and obey all the rules. And I said, no, I work in Scottish Government. I deal with health inequalities. And they said, what's that about then? And I said, well, I don't know if you read in the newspaper, but it said that the life expectancy in one part of Glasgow, Lenzie, was 84, and in Carlton it was 56. And one of the guys just raised his finger right in my face and said, it was 54. And he burst out laughing, and he said that they were all from Carlton, and it was really an enlightening and important experience. I'm feeling Trish whispering in my ear about the importance of listening to people. And I said, so they said to me, what's that about then? And I said, oh, some of it, you know. And he said, yeah, how we smoke, how we eat, what we drink. I said, but that's not a sufficient explanation. You know, clever maths have been done to establish that that does not explain on its own the life expectancy difference being quite so great. That's the context of Scotland. And so and this morning, when Sanjeev told me the title, What Counts as Evidence and Whose Evidence Counts, I added the latter bit. I just happened to be listening to the radio where was about the scientific method, whereas we would like our stories about the world to be true and as simple as they can possibly be, and to have as large an extent of applicability as possible, to be universal. But the world, as finance ministers or indeed health evaluators keep discovering, is messy and complicated and hard to explain or predict. We would like there to be a series, particularly in central government, of methods or recipes or rules that we could apply and guarantee would work. Clearly, it ain't going to happen. Sanjeev asked me if I put this slide up. I was the lead for health inequalities, but also later for long-term conditions and supporting people around health literacy. And someone at a World Cafe event drew this on the page that said, this is my life, the green line. This is me living my life. You come in 4 times a year for 20 minutes and think that you're controlling, you're running my life. You're deluding yourselves. It's and it really did put the emphasis on the importance of health service and health and care service interventions really being about the red lines and how they can be maximized. And I was also the lead for health literacy, and I've put this up just as a nice visual reminder that often, number one, communication is framed as from the expert on the left to the stupid person on the right. And the person on the left is the person using the language which can't get through. Who is the stupid person? And it's really important that that obviously we speak to people in terms they like. Now, I was very engaged with a piece of work called The House of Care, which was about using a very simple model. Now, I would say all models are wrong. Some are helpful. I particularly have found this one helpful. And if I quickly give its origins, which some of you may know, which is about the chronic care model from Ed Wagner, who said, these are all the elements. And I think if I went on to a blank slide, it would be quite hard to remember. And the House of Care is just a redrawing of that. But it does have at its heart a conversation with people about what matters to you. And that to have a conversation, you need to have 2 parties. So you really do need to engage with informed, empowered individuals and carers. And if you think about what empowered means in the context of inequities, it really does raise those issues of race and gender, which have been touched on already. And the healthcare professionals, do they tell the person what's good for them, or is that space in the middle a space where 2 experts meet? Experts in perhaps in some aspects of health and care, and then people who are experts in their own lives. And the fact that you need much more than just medicine and their intervention in order to enable people to live and die well. And that the health system, the organizational arrangements need to be there as well. And I quite like to draw it as with Fred Astaire and Ginger Rogers in the middle, because it means that Ginger on the left for the patient has to do everything that Fred does. But backwards and in high heels. Now, I need to go on to is the slide view showing now? Sanjeev, is the slide view showing?
Yes, we can see it. Yeah, go for it.
Yeah, so basically the point of this is if one element is missing, the whole thing falls down. You can't say, oh, the empowered patients doesn't matter. The whole picture matters. But sometimes I think, particularly in our analyses, the emphasis on the roof just means that we focus on our bit and everything else is just crushed. And so you could see that was a very personalised view. But for us in Scottish Government, we found it very useful as a model, because it enables us to keep that focus on a conversation with people about what matters to them at the center, and to identify the elements that need to be in place to support for example, the health and care team, and then nationally, the things that need to be in place. Now, when people were speaking earlier, I had the advantage of going fifth, and I thought that many of the things I would want to say were said so much more eloquently and with such excellent lived examples. So Trish saying, we adapted it with them. And I think that a big experience for me in policy has been the retaining the capacity to be surprised, to not know what is good for people. And then Sana saying, who decides what counts as a good outcome? And see what women have to say about the outcomes. And then Diane saying, there are no playbooks and solutions are created in real time. With space for their own moxie. You were applying it, I think, Diane, to the workers, but I think it's also to the people, asking them what will work with them. And Sanjeev, you spoke about the different learnings, and I guess there's a values learning, which is about, goes back to the guys on the train, and realizing that I had perhaps been thinking of them as foolish and not knowing what was good for them, when they knew damn fine what was good for them, but their context constrained them, and that there was a values learning for me, and the value was one of respect. I think that's me. I don't know if I've got to 10 minutes. I put some more links in here to just touch on some of the things I've spoken on, which can be shared afterwards. And but I was particularly struck by the article from The Guardian with Dr. Dennis Mukwege. I don't know if that's how you say his name, who went to France to train as a clinician and then went back to the Congo. Yeah, you can look it up if you're interested.
Tim, thank you.
I think he won a Nobel Prize.
Okay. Tim, thanks a lot. Usually Ray has an easy time. I don't think he's going to have an easy time today, I think. But for a quick, I loved your call out for thinking about values learning, and also in a way that forces us to become more modest. Absolutely love and I've not heard the phrase in a while, retaining the capacity to be surprised. That would be music to Ray's ears, certainly music to my ears. I think that's part of evaluation's job. It often doesn't happen. Just working backwards, the importance of listening and the way you've connected, and that multiple speakers have spoken.
Sanjeev, can I say one thing, which is that I think what I should have said, as a policy person, you often have to, you're playing a strange game of chess on multiple levels, where you have to construct stories which are persuasive of your political masters as a civil servant. And I'm sure others would recognize that, constructing stories which are persuasive, which plug into the evidence and are not just are more than just anecdote. And that is a challenge. It's not needing the evidence. It's always having to think, how can, on a burning platform, how can you make this issue and the needs of the most discriminated against, the least powerful voices heard?
Lovely. Tim, thank you so much. Tim, if you don't mind, stop sharing. Over to...
I don't know how, it's not letting me, how do I stop sharing?
You have, it's already works. Over to you, Ray.
Okay, can you hear me? Can you see me? Good.
Yes, fantastic.
Good. Right. Good morning, good afternoon, and good evening, everyone. And thanks to Paho especially for the privilege of letting me speak last in this splendid series. I really should get excited about the previous speakers. They're all gorgeous. And what was interesting was that each one of them had their own ecology of evidence. So they were all dealing with complex situations, and the range of complexities that they went through was amazing. Add them all together and you get some real understanding of the enormity of evidence that you need to follow and understand a program through. Some of those bits of evidence surprised me, some about ghosts and some about Fred Astaire and Ginger Rogers, but the point holds that complex interventions need complex bodies of evidence, and we need something, this mysterious ecology of evidence to understand them. I've not introduced myself. I always say I'm a humble methodologist, a mere methodologist. Sanjeev rather rudely described me as one of these distant academics. But never mind, I'll plow on. So what I just wanted to try and wrap up with are 3 important methodological points about this idea of the ecology of evidence. Okay, so point one, the precursor is, this is really important. Ecology of evidence is going to become a central concept in methodology. First point about it, however, it is a warning. It contradicts another great edict called a hierarchy of evidence. So we have the ecology of evidence in the blue corner and the hierarchy of evidence in the red corner, and they will fight. Those of you that don't know, the hierarchy of evidence comes from the clinical sciences. It suggests as a hierarchy, the best gold star evidence comes at the top in randomized, placebo-controlled, double-blinded trials, and you go right down to the bottom where you get testimony, practitioner wisdom, and patient testimony, and they are not regarded as valid and reliable evidence. The ecology of evidence shifts that round and creates an equal plateau. I'll say a little bit more about how equal in a minute, but the point is that these perspectives will fight. Now, I'd love to be able to talk more in detail about this, but if you look at the advice that the British government, the scientific advice that the British government is being given on COVID policy, it belongs in one corner. That is to say, the body, by the way, is called SAGE, the Scientific Advisory Group on Emergencies. And the Scientific Advisory Group is basically packed with epidemiologists, clinicians, mathematical biologists. The only social scientists that have a say are behavioral scientists, but their remit is very much limited to how do we communicate these policies. So at the top table, there's a huge gulf, a huge missing sector. COVID policy is basically about social control, social engineering. It's a massive program of social engineering, and yet there are very few policy analysts, evaluators on board, and that I just issue as a warning. That battle will maintain itself. Secondly, a simpler point about the ecology of evidence, and this is important. I don't think the ecology of evidence means the equality of evidence. It doesn't mean that everything counts. It doesn't mean that everyone should have a say. And here I might slightly contradict some of the previous speakers. I don't think there is an open house for evidence. I think if you permit all opinions as evidence, you hover near post-truth. And I think there needs within evaluations there still needs to be some notion of the worth, the quality of evidence. It can be of quite different kinds, but it still has to permit inferences, and that has to be tested. My final point, I'm trying to be brief here, is the challenge of the ecology of evidence. What we've learned in a mere 90 minutes is that the body of evidence that you need to evaluate programs is potentially vast. if you go back to some of Sanjeev's slides, there are an enormous amount of activities, enormous amount of expectations that are now going to be placed on evaluators. And so my question is, can they possibly cope with it all? And that becomes increasingly difficult in the way that evaluation tends to be organized. That is to say, every program is considered unique, never tried before, never applied to this population, never applied in this particular way. So the poor evaluator, now confronted with the need to gather the ecology of evidence about this emerging program, simply will not be able to cope with the need to the chance of acquiring evidence on all of the possibilities. Is there a solution? I think there is, and I think it's this, and I take my lead here from Mark Twain. Yes, Mark Twain, the American novelist, and he has this beautiful little motto which goes like this: history does not repeat itself, but it often rhymes. History does not repeat itself, but it often rhymes. The same goes for social programs, public policy. They never repeat themselves. They never have the rhymes. There is a rhyming quality. There are similarities and differences between and across programs. So this means to me that evaluation, the collection of the evidence base, the ecology of evidence, should work in the opposite direction. It should work from the history of programs to what's happening in a current particular program. So I actually think that funders like Sanjeev and others should concentrate more on synthesis of the previous history of programs, synthesis of similar programs, of which there will be dozens and dozens. I wouldn't dare to put a figure on that proportion, but I do strongly believe that we can learn from past events, and that's where evaluation should begin, and that's where the ecology of evidence should begin. That's me finished. Thanks, folks.
Great. Thank you so much. Lots to comment on. I'm going to keep it moving, but I just can't help but say, I just love the poetry of your comments and the comment on Mark Twain. I say there's not many evaluators who have been able to do that. I'm going to take a few questions. I'm going to start with Jessica's question. It's about values. Our experience working in maternal health is similar and seems to be different in values. Physicians believe the most important factor is quality of medical services, but does not value how services are provided. By dismissing the value of how the care is provided, physicians are not allowing the problems of poor maternal outcomes to be addressed. Let me read a couple of comments. That's one, that's Jessica. Lewis says, and that connects with your comments, Ray, on the characterization of the hierarchy of evidence, it's worth noting that it depends on what the questions are. Depending on the nature of the questions, it can well be that social sciences provide the best of studies. That is not to say that RCT is the best. It is not to say RCT is the best response for everything. Ray, let me come to you first. Any thoughts on the issues of values? The fact is that each of us bring our own organizational lens, our own incentive structures to a problem. So it's hardly surprising that you gravitate towards some kinds of evidence over others. Any role of evaluation for some kind of values resolution, et cetera, et cetera. Ray, and any other panels?
You've provided the answer in your question, Sanjeev. That is to say, you've recognized that different values are based in different locations, in different structures. So if you withdraw and ask that question, you can begin to appreciate there are different values without saying, and I like that lot of values better than that lot of values. You work at it from a meta level.
Lovely. Tim, Sana, Diane, and Trish. This question really resonates. Tim, let me come to you first.
Yeah, I would just say I feel too white and too male to answer this question first, and will pass.
Okay. Let me go to Sana.
I find this question of values absolutely pertinent to what Ray was talking about with respect to evidence, that one isn't arguing for an open house of opinions, but then there's evidence and then there's evidence. And I'm not so sure that the drift towards post-truth has to do with the lack of rigorous evidence, but rather the values with which people are approaching that evidence. And I'm not sure that more evidence is the answer to that. So I wouldn't close the door for different kinds of evidence in the ecology, but I would question perhaps whether we are hoping to bring about social change through presenting certain kinds of fact which don't really convince. And the fact that that's not what social change has ever been about. It's not about what the real truth is. It's about what we value at the end of the day.
So Sana, you're providing both an answer to this question, and do I see a slight difference of opinion with Ray? Am I hearing? Yeah, lovely. That's music to my ears for more reasons than one. Diane. Diane, are you there? And we come to Trish. Trish, thoughts on values?
Perfect, thank you. I'm not sure that I have anything additional to add from what Sana and Ray said. And while there is some contradiction in there, I also really appreciate that contradiction. Lovely. I think that's what we need.
Yeah, I think it's no point having an ecology of evidence if you cannot have an ecology of views. So I just think it's really critical that there's at least some gentle friction here. Let me. Anything to say about? It depends on the questions. This is sort of Luis Gabriel's point on the hierarchy of evidence. It depends on the questions being asked, and in some sense, I'm going to sort of frame it slightly differently. I guess my question is, where do these questions come from? Often as a funder, I'm very sensitive to, and I don't think I often do a good job of not imposing questions on these are things we want to learn. And as I say, it's very often, so I'm never really clear what's the source of these questions itself too. Any thoughts about this general comment on the hierarchy of evidence? And really depends on the questions. And so some questions does require hierarchy of evidence, if I'm understanding the implication right. Ray, can you, let me turn to you to also, I feel like I'm getting tied up in knots here. Any quick reflections from your side?
This is too complicated to deal with in a very brief answer. But I would say, because I've looked at this, even the clinical scientists, even in clinical science, there is argument about the hierarchy of evidence. And one thing that's missing is basic biology. Fundamental biology. Now, if you think of vaccination and COVID, what counts is the understanding of cellular receptors, and that isn't in an RCT either. That's long-term theoretical development of biology. So I'm allergic to any fixed hierarchy of evidence in any discipline.
Lovely, fantastic. I have a feeling none of the panelists are going to disagree with you on that one itself too. Ray, your comments on Mark Twain and rhyming has gotten a lot of attention, and I think you need to mine it much more. Jeff Matthias, I think somewhere in New Zealand, writes, so I reckon the rhyming qualities about the generalizable nature of evidence. non-repeating about context-specific stuff. Andrew Gray, and there's two last comments. And Andrew Gray says, we've not given the distinctions between inequalities and inequities. Its due are not the same, and they call on different values and in the ethics of evaluations. He says that Mel, as I would expect, also tries to match Ray's poetry. I need to shift to another meeting, but wanted to say thanks. A phrase comes to mind, not from Mark Twain: evaluation or evidence should be an aid to judgment, not a dispensation from it. All right, I see many other comments have come too. I know we are on at time. Let me just come for last quick summary comments. Let me start with you, Tim. You've got 30 seconds.
Just so much to reflect on. I suppose it's the thought about the post-truth kind of world, that whether or not we live in one, we still have a duty to construct a clear understanding, to write a story that makes sense and inspires action, and to recognize that who will benefit or not from the way that we frame our story.
I see you lean towards Sana's camp here. Trish.
Sanjeev, thanks again for inviting me to such an interesting discussion. And I'm always amazed how we can have panelists who are all talking about different things, but in the end, it comes together and complements each other so well to have sort of this global vision of different ways to be looking at things and different questions we need to be asking. So thanks for that.
Ray.
Nothing to add except the next seminar series, I shall start with The Life and Times of Tristram Shandy. Now, there's enough.
That's lovely. Sana.
I have to agree with Trish. It's been an absolute pleasure to hear everyone talk about their programs. And I work in a fairly small space, and it always surprises me how much there is to resonate with across the world. So yeah, it's been an absolute pleasure. Thank you.
Diane Walton. Diane, are you there?
Hi, Sanjeev. I'm sorry, I had to leave. A call came in from the city, which I had to attend to. I was particularly, what interested me, I believe Ray made a statement that testimonies are not seen as evidence equal to other evidences. And I'm particularly, that I feel is an inequity, I must say. And Ray, we've got to work on that piece. And I'm thankful that I was invited today. I certainly learned a lot from the presenters. Thank you.
Lovely, lovely. No, it's simply a delight. I have this, I do this very often, as many of you know. I have this strong intuition that this webinar has legs. This one, and some of even the last second jabs is wonderful and exciting, that I feel like, oh, we're going to come back to this. So Diane, you've not heard the last of it. I hope the city did not hear too many of your comments, and that the call had nothing to do with your comments in this call, talking about real-time problems. Oriel Solar, back to you. This was absolutely a fantastic, exciting session. Over to you, Oriel, Antia, over to you, please.
Thank you very much for all the speakers. Were very great session, and also I think that we got the passion, the compromise about this issue, evaluation and plus equity, and this is fundamental. Voy a hablar ahora en español. Dar las gracias nuevamente a todos los expositores, y a todos los que han acompañado estas 3 sesiones de webinar, Y creo que ha aquí marcado en esta última sesión la importancia del compromiso con respecto al tema de evaluación y al tema de cambios, cuando uno quiere abordar los temas de equidad. Y creo que algunas palabras que a los teams en relación a no dejar de sorprendernos, y que tiene que ver a no dejar de emocionarse y no normalizar la desigualdad y las inequidades, algo tan presente en nuestra región, es fundamental. Así que nosotros muy contentos y queremos contar a todos los que han vinculado, han estado presentes en los webinars, nosotros proyectamos esto para el próximo año, algo señaló Sanjeev en el inicio. Esperamos realizar algunas acciones del próximo año y iniciar un proceso, ¿no? de crear capacidades de evaluación, de ampliar la visión de evaluación, de superar los pragmatismos que a veces nos limitan poder tener cambios, ¿cierto? Y nuevas soluciones, ¿no? a lo que hacemos. Así que muchas gracias a todos y todas por la hora. Nuevamente el link de los webinars están puestos en el chat. Nosotros igual les haremos llegar a todos los que se han inscrito y nuevamente darle las gracias a todos los invitados, los oradores y a Sanjeev en particular, ¿no? Muchas gracias.
Thank you, Oriel. Thanks, Tim, Diane, Sana, Trish, and of course, Ray. Thanks for everything. To be continued. Cheers. Bye-bye. Bye-bye.